Hello, my name is Natalie Phillips. I'm a consultant gastroenterologist and hepatobiliary specialist based at Hammersmith Hospital Imperial Trust. I was involved in the pancreatic OncoSil trial as an endoscopist implanting the OncoSil. Sadly, approximately 10,000 patients are diagnosed with pancreatic cancer every year, and despite treatment so far, the prognosis has still remained one of the lowest of any other cancers, approximately 5% at 5-year survival. Anything we can do to improve that survival has to be a good thing. Now, the mainstay of treatment for pancreatic cancer is really based on whether it's resectable or offset, and the minority of cases are, sadly. Patients who have non-resectable cancer, pancreatic cancer, would be treated with chemotherapy or chemoradiotherapy traditionally. New developments have been based on other cancer care developments, such as for prostate cancer, endometrial cancer, included other therapies such as nanoknife, and in the case of brachytherapy for pancreatic cancer, OncoSil treatment. And all of these developments are very promising and exciting opportunities for treatment for a cancer that up until now has such a poor prognosis. The NHS is largely stretched at the moment in the post-pandemic era. A lot of the NHS trusts have fantastic recovery strategies in place to deal with this. However, the workload is still substantial. We're very much looking at clinical trials and availability of specialists to undergo new treatment pathways at hospitals, but unfortunately that's very much dependent on or variable within the NHS, depending on site at present. ERCP, which is an interventional procedure performed by endoscopists, has been used for a large number of years to help with relief of symptoms from pancreatic cancer, primarily jaundice, and occasionally in terms of diagnosis of pancreatic cancer as well. But EUS therapy has really transformed the way that we can diagnose, stage and treat now pancreatic cancer. It's a very exciting area for development. EUS therapy is used for diagnosis. We can take tissue samples, we can look at staging the cancer, and in the advent of brachytherapy in terms of OncoSil, we can now deliver treatment directly to the tumour itself. We're learning more and more about the tools that we can use endoscopic therapy for using EUS, and it's a very exciting area for development, which I think will only increase in the coming years. The procedure itself is not technically difficult to do, but the planning does require some work. That includes the patients being discussed in an MDT environment, checking that they're eligible for the treatment, and most importantly, a walkthrough of the procedure and how we were going to undertake that, with good contingency plans for if things did go wrong. Luckily they didn't, but just in case they did, everybody was very clear on their role during the day and what to do in the event of an adverse event occurring. The PANCO study was very exciting and interesting to read. Most importantly, and I think this is always the mainstay of all our treatment for patients, it has shown that the administration of OncoSil is safe. The results of the PANCO study were very encouraging, including the ability to change people from locally advanced pancreatic cancer to resectable, with 33% being potentially resectable and 24% going through with resections that may have been due to comorbidities or patient choice. I think overall the PANCO study is a very promising and encouraging study to read for patients with pancreatic cancer. OncoSil provide very comprehensive guidelines for decontamination during the OncoSil procedure, and there are specific areas when you're providing the endoscopy for this where you can help with reducing the risk of contamination. This includes leaving the needle exposed in the stomach and flushing with fluids at that point. Also leaving the needle exposed as you remove the endoscope, and then washing thoroughly when the scope's removed. This is an area actually where we sort of moved away from the OncoSil guidelines to wash down the scope more thoroughly than had been initially suggested. And in our cases, we only had one case which was actually showing any tracer activity after first wash down. And with second wash down, there was no tracer activity. So we had no ongoing problems with decontamination. But there's always the discussion about if there is contamination still present on the scope, what do you do then? And contingency plans are always available for that. So the procedure of implantation of OncoSil is an very exciting one to do as an endoscopist, but is not technically difficult for any endoscopist who's experienced with EUS and is used to taking biopsies for pancreatic cancer. The procedure is much the same, except that you're implanting OncoSil rather than removing tissue. I think that really the important thing to remember as an endoscopist is that always you can choose not to implant if there is significant risk to the patient on that day. And that includes not having a window for implantation due to overlying collateral vessels. I think it's fantastic that the insurers are behind the OncoSil treatment. We now have 2 insurers that are providing this treatment, which would otherwise potentially be prohibitively expensive for patients. This can only be a good thing for a cancer that has such a poor prognosis and very limited treatment options at present.